My name is Rajiv Gupta and I'm a neuroradiologist at the Massachusetts General Hospital. Today I'll be talking about impact of reviewing our CT doses, lessons learned at the Massachusetts General Hospital. The outline of this presentation is as follows. I'll first talk about in the context of head CT, what is it that we need to see and why there is this proclivity or there is this desire to have as good an image as possible. Then I'll talk about a partner's dose survey and the results of what we found out when we reviewed our own CT doses. And then I'll talk about the response and the results of our response to the survey. So here's a 50-year-old patient with new onset neurologic symptoms. And in a busy practice, it is very easy to sort of walk by the slide and say it is normal. However, there is an abnormality on this slide. And if you look at it carefully, what you will see is that on the left-hand side, the anterior ACA territory has a loss of gray-white differentiation. So we need to have very good gray-white differentiation in all our images. And obviously, the easiest way of doing that is to increase the dose so that there is less speckle and the image quality is improved. We verified the fact that there was indeed a loss of gray-white differentiation in the left ACA territory by doing a CTA, and as you can see, the left ACA is out, and the perfusion on the left side of the brain is diminished because of that. And you can verify that on the DWI image where there is restricted diffusion in the ACA territory and some surrounding areas. Here's another case, a different patient after trauma, and you can see that there is a subdural hemorrhage on the right-hand side, but there's a much larger subdural on the left-hand side. And the subdurals are marked by these red arrows. You can see that there's a left midline shift to the right-hand side. And what we need here in order to be able to diagnose this is proper Hounsfield calibration as well as good, very good cupping correction underneath the calvarium. If there was artifacts, there were cupping artifacts, it could be possible to miss a small subdural because of that. Here's a case of an 11-month-old who had trauma to the oropharynx, and you can see that there's a large retropharyngeal process on this lateral view of the oropharynx and nasopharynx. When a CT scan was performed, you can see that there is a subtle change within the soft tissue density in the retropharyngeal area, which is marked by these arrows. And on a different slides, you can see that there is a focus of air. You can also see the path of the trauma within the oropharynx. So what we need is very good soft tissue discrimination, and one easy way of accomplishing that is to increase the dose so that you have less speckle and the soft tissue discrimination is as good as possible. Here's a different case, of a 44-year-old who fell from a tree. There is trauma to the orbit, and there was this air density that was seen in the retrobulbar region, which is marked by these arrows. This was thought to be some air that has dissected in the extraconal retrobulbar region, and this patient was discharged. The patient continued to have pain, came back after 2 months. There was proptosis in the left globe, and you can see that there is large amount of enhancement within the area, and there is a small area within it that is not enhancing. This patient was taken to the operating room, and what was taken out was this piece of wood which had lodged itself within the retrobulbar region. And it's only within the subtle difference between the density of wood and the density of air where the information actually lay. So it is very important to have proper Hounsfield unit calibration, and we have to pay attention to the fact that air and wood can look very close to each other in Hounsfield unit. Here's another case where there was history of trauma, and there's a subtle fracture in the right occipital bone that is marked by these black arrows. And there is also some soft tissue swelling in this area, which is what drew our attention to it. And it is very important to have very high spatial resolution in these scans, which necessitates then concomitantly larger amount of dose, because without that, it is possible to miss this very subtle fracture. So we need very high spatial resolution and very high MTF. Here's another case of a 4-year-old with a history of headaches, abdominal pain, anorexia, and vomiting. What you see right off the bat is there are a lot of artifacts in the posterior fossa. And among these artifacts, it's not clear if this hyperdensity that we see, if that is real or artifactual. In fact, it was not noticed in the first scan. However, in subsequent scans, it was found out that this patient has a large mass in the clival region. In fact, the entire clivus is eroded through the tumor is visible on nuclear medicine scans, and it's also visible on this enhancing and is visible on this post-contrast T1 weighted images. So again, we need artifact-free posterior fossa. Here's another case where there's a lot of beam hardening artifacts within the posterior fossa. In fact, it's not clear from the scan if there is an abnormality or not. However, when contrast is given, you can see there's a large rim enhancing lesion within the posterior fossa. So we need an artifact-free posterior fossa. So if you were to summarize all the requirements, what we see is that we need good gray-white differentiation, we need proper cupping correction, good soft tissue discrimination, accurate and reliable Hounsfield calibration, very high spatial resolution in MTF, and reduction in artifacts in posterior fossa as well as elsewhere within the visualized brain. So, and these requirements, even though I've showed them with the examples of neuro imaging, they are across the board. They are true. These are some of the requirements that are needed in all parts of the body. And so we can understand why there is a desire to have very high quality images, and an easiest way of doing that is to increase the dose on the scan in order to acquire high image quality. So in order to keep these two things in balance, in order to have dose as low as possible, at the same time have the image quality as which is required to make the diagnosis, we conducted a dose survey across the partners institution. And what we did was we examined consecutive patients and tabulated their dose across a host of CPT codes, and we tabulated them on different scanners in different institutions and for different indications. And here are some of the results of that. So what I'll show you are some selected slides. This is the survey, a subset of the data just for head CT. On the left-hand side, you have the CTDI for different scanner types and for at different institutions. And on the right-hand side, you have the DLP, which is given by these blue bars. The CTDI value is given as the red curve. And what you see is that there is large variation both in the DLP as well as in the CTDI. So for the CTDI, the value is going from something like 45 at the lowest level to over 80 at the highest level, nearly 100% increase in dose from the lowest to the highest. And the same thing holds true for the DLP value. There's almost a 200 to 300% increase in dose from the lowest to the highest value. Okay, and we're doing the same scan. It's basically a routine head CT without contrast. Why is there a large variation in dose across institutions and across different scanners? If you look at CTA of the head, this is a summary slide. Again, on the left-hand side you have the CTDI, and on the right-hand side you have the DLP. And you see that the value of the CTDI valve is changing from a low of about 30 to a high of over 70. Similarly, the DLP is changing from about 1500 lowest value to about 3500 the highest value. So over 100 to 200% change in the value from the lowest to the highest, both in the CTDI as well as in DLP. So to me, this was unacceptable, and we systematically studied as to why we are having these changes. The conclusion of the survey was there's large variations among the sites and across scanners, and less used scanners had what we would call a dose neglect. There were some protocols on them which were less often used, however, were not properly set up. And the insight really was that it is not about the science of scanning, but really about the process of scanning. So if we paid attention to how we are regulating our protocols, maybe we can bring the overall dose down and the average dose level to a much more acceptable level. So we instituted a number of changes, okay, and these changes are summarized in this one slide. In this 15-minute talk, I cannot actually go over all the details. However, I can summarize for you what are the various things that we did in order to respond to the large variation that we witnessed in our dose survey. First of all, we instituted decision support within the radiology order entry system. Okay. So every time a physician goes to order a scan, the system will inform him these are the other scans that have been done recently, what is the level of evidence for the indication that he is trying to get the scan for, is this a well-justified scan, or if it's not a well-justified scan. So if you order a head CT for a minor trauma with no loss of consciousness, and essentially the system will tell you what is the level of evidence that the scan that you're ordering is correct or not. And we immediately saw an effect of that most clinicians would hold off on a scan if there was not good clinical evidence that the scan would be efficacious in finding the diagnosis that they were after. We also instructed our technologists to pay attention to the mechanics of scanning. For example, are they centering the patient properly? Are they giving the breathing instructions properly? All those things matter a lot. For example, centering determines how well the automatic exposure control system works. So if the scan is well centered, the AEC will take care of minimizing the dose if you're using that. And that is very important, that the scan is not only the patient fits in the field of view, but it is within the center of the field of view. We instructed the technologists, and we also went through all our protocols to make sure that we are using minimum MA, and whenever possible we are using MA modulation, auto MA or care dose or whatever the vendor specific acronym was, but we are using dose modulation or tube current modulation whenever it was available. We also switched to auto KV, or automatic selection of KV whenever it was available. We also found that many scanners had what we would call a protocol clutter. There were like 3 different head CT protocols. There were 5 different head CTA protocols, all named 1, 2, 3, or named after people who had designed them. We tried to get rid of as many protocols as possible and keep to a minimum level of well-tested protocols. We also tailored protocols to clinical situation, and we came up with categories of protocols. So if it's a repeat scan, it doesn't have to be done at the same dose as a scan where we don't know anything. And so similarly, sinus CT can be done at a very low dose. Temporal bone CT, because we're looking at bony anatomy, can be done at a very low dose. We paid special attention to pediatric scans, and we made them weight specific and age specific, so that we are using the right protocol which is matched to the pediatric patient at hand. And finally, and probably one of the most important changes was that we made one person responsible in each division for managing the protocols. All changes were instituted by this one person who was responsible for coming up with a consensus and then making the change. And the overall attempt was to minimize variability as far as possible. So let me show you what is the final outcome of all this work. What I'm showing you here is a slide that shows last 50 consecutive patients that were scanned on this particular scanner, CT 750 HD scanner. And as you can see, the dose is much more uniform, and on the average, we are scanning patients at about 30 milligray. Okay, that is our head CT protocol dose today, and which is very close to 1 millisievert, and it is uniform across the board. We don't see large variations in it. So we are very proud of the fact that even though we started out with much larger variation, now if you were to reconduct the entire dose survey again, you'll find much more uniform dose, and a dose that is much lower than what was there 4 or 5 years ago. So in summary, the science of radiation dose is important. However, how we institute the protocols and what are the operations that we have in place, the mechanics that we have in place for managing these protocols is equally important, and we should pay attention to. Thank you.